Clinical examination of the respiratory system. Breath sounds. Let's look at auscultation. So auscultate the chest for breath sounds and avoid using the diaphragm of the stethoscope, as in a hairy patient. The friction between the hair and the stethoscope will produce crackling sounds, and you may confuse this with adventitious sounds in the chest. Also, in a very thin patient, it may be difficult to get the diaphragm flat on the chest wall. So it's advisable to use the bell of the stethoscope in auscultating the chest for breath sounds. Instruct patient to take deep breaths in and out of his or her mouth, and know the pattern of breathing. Be very gentle with patients with pleuritic pain who will be unable to take deep breaths. It is vitally important to compare the two sides at each position that one listens. You must compare with the corresponding position on the opposite side. So listen more than 2 to 3 centimeters away from the midline, so that you listen over the chest, over the lungs rather than the airways. The normal sounds may be reduced or absent if there is a barrier to their transmission, as in pleural effusion or pneumothorax, or when airflow is reduced locally to a part of the lung. For example, in lung collapse, the breath sounds will be quite bilaterally in obesity, and it will also be quiet in hyperinflation and when ventilation is depressed, as in an unconscious patient. The sound one hears over the normal lung is described as vesicular. It is like the sound one hears when the wind blows through the leaves on a tree. When the lung between the large airway and the chest wall is relatively solid, the breath sounds are transmitted with much less loss than the normal and are called bronchial. This is like blowing sound through a narrow tube. Bronchial breathing is therefore heard over consolidation, collapse, and sometimes fibrosis. Bronchial breath sounds are normally heard by listening directly over the larynx or trachea. In bronchial breathing, the sounds are harsher with high frequency and have a definitive pause or a definite pause between inspiration and expiration, and can be heard throughout expiration. Other terms used to describe variation in breath sounds are tubular, when the sound is the same as bronchial, and bronchovesicular, which is a combination of the normal and the bronchial breath sounds, and also cavernous or amphoteric. So amphoteric, when the sounds appear to originate from a cavity beneath. Okay. So tubular is the same as bronchial, bronchovesicular, combination of normal and the bronchial breath sounds, and cavernous or amphoteric, that is when the sounds appear to originate from a cavity beneath.